So, hello ladies and gentlemen. This is a continuation of our ongoing series of lectures on anesthesiology. And this particular lecture is a continuation of the management of pain, which we started in the last lecture. We're going to spend some time in this lecture talking about the many other forms of medication that are used in management of pain. We're going to talk about 3 patients and how one would go about managing their pain. And then we're going to end with a discussion of obstetrical analgesia and how we manage pain during obstetrical care. So these are some of the drugs we use, and these are classes of drugs. There's opioids, which we've already talked about, non-steroidal anti-inflammatory drugs we've talked about. We're going to talk a little bit about tricyclic antidepressants, serotonin norepinephrine reuptake inhibitors, anticonvulsants, NMDA receptor antagonists, alpha-2 agonists, 5-HT1 agonists for migraine, and then we've already talked about nitrous oxide as an analgesic. We won't come back to that. So opioids, as I've mentioned, act on the mu receptor in the brain and spinal cord to produce both effects and, unfortunately, side effects. And the side effects are common: respiratory depression in higher doses, nausea and vomiting at very low doses, constipation, extremely common, sedation, very common, dizziness, sometimes euphoria, but the majority of people have dysphoria, which is the opposite of euphoria. Instead of feeling happy, they just feel generally lousy. Confusion, muscle rigidity, pruritus are also potential complications. These drugs are ideal for managing acute pain, but are often ineffective in chronic pain and lead to dependence, as we've talked about. We've already talked about tolerance and physical dependence. They can lead, of course, to addiction in those people who are susceptible. Remember what I said earlier, physical dependence occurs in anyone. So none of us are able to prevent ourselves becoming physically addicted to these drugs. It happens to us all. But the majority of us hate them and don't find any need to continue them once the pain is well controlled. So once the pain is gone, we're able to stop the drugs. We go through a short phase of physical withdrawal, which may include some sweatiness, nausea and vomiting, general unpleasant feeling. But most of us don't want to use them anymore. We don't like these drugs. Addiction occurs in those people, relatively few, who get this high or this euphoric phase from opioids, and they become drug seekers, and they become incredibly difficult to deal with and manage and help. Here are a few of the drugs that are commonly seen under the opiate banner, and I'm only going to go through this briefly just because some of them you're going to surprise you, that they actually, a lot of them just turn into morphine when they're given. So codeine, which is used as usually in very low doses as a non-prescription drug and in higher doses as a prescription drug, is rapidly converted to morphine in the liver. So you take it orally, it goes to the liver, it's turned into morphine. The dose of morphine is very small, but that is what causes the analgesia. It's commonly used also as an anti-cough medication because all opiates suppress cough, and it's a mild analgesic. I hate this drug. The side effects are very common, and some medical groups, including the Canadian Medical Association, have urged that it be removed from the market, but the Canadian government hasn't caught on yet, and it's still out there. Heroin, the drug which most addicts will tell you is the drug that gives them the best feeling, is also converted to morphine when it's given. There is no evidence in the therapeutic literature that heroin is a better analgesic than morphine. But addicted people will tell you that it produces more euphoria than morphine, but those studies are inconclusive. So why do people crave heroin? We really don't know. It doesn't appear to have any particular properties that make it either superior or very different from morphine, and the active agent from heroin is morphine. Fentanyl is a drug that's now widely used for the treatment of chronic pain that was initially only used by anesthesiologists. It's a very potent drug, 100 times more potent than morphine. It has an intermediate duration. It's used by anesthesiologists, emergency physicians, intensivists intravenously, but it's used in chronic pain management primarily in patches. Percutaneous or transcutaneous fentanyl patches can be effective in reducing chronic pain. Sufentanil, another drug in the same family, is 1,000 times more potent than morphine. It's also of intermediate duration, and it's used almost only by anesthesiologists during surgery. Remifentanil is an oddball opiate. It's 70 times as potent as morphine, but it has a half-life of only 1.5 minutes. So it's given by infusion rather than by intermittent injections. It's also not metabolized in the liver as all other opiates are. It's metabolized by ester hydrolysis in plasma. And it's given, as I mentioned, only by continuous intravenous infusion. And I'm unaware of anybody other than anesthesiologists using this drug. So the good news when it comes to opioids is that although the agonists are very complex and difficult to manage in some people, it's actually incredibly easy to reverse these drugs using either naloxone, which is given intravenously, has a very rapid effect, seconds before it reverses the effect of the opioid. It's given primarily by emergency physicians and anesthesiologists. Emergency physicians tend to use fairly high doses, and this can cause accelerated opium withdrawal in patients who have been addicted to the drugs. Anesthesiologists, being a more conservative group, we tend to give very dilute naloxone and give it in small aliquots. And this technique actually allows patients to resume respiratory activity with relatively little effect upon return of pain. So patients' pain control remains reasonably good and they breathe, which is the goal of all of this. Naltrexone is exactly the same as naloxone in its action, but it's longer acting and it's used in the treatment of both opioid addiction and alcoholism. And I honestly have no idea how it works in alcoholism because there is no similarity between alcohol and opiates, either chemically or in terms of their actions on the brain. The interesting things about naloxone and naltrexone is that if they're given in the absence of opioids, they have virtually no physiologic effect. So they're quite safe drugs to use, and they can be used to help people who are addicted to these drugs. Commonly used drug as well are non-steroidal anti-inflammatories. The great-grandfather of all these drugs is aspirin, ASA. The newer drugs tend to be either relatively short-acting and low potency like ibuprofen, or they can be very long-acting and have very profound effects on the cyclooxygenase enzymes COX-1 and COX-2, and reduce the production of prostaglandins, which are present in inflamed tissues. So the reduction in inflammation reduces pain, so that's where they become analgesics. They also reduce the recruitment of leukocyte, white blood cells, which produce inflammatory mediators. So they both go in and help moderate inflammation and prevent further inflammation from forming. So side effects of nonsteroidals are not inconsequential either, unfortunately. And gastric hemorrhage is still a relatively common event in people who are taking high doses of these drugs. They're very irritating to the gastric mucosa. In addition, they interfere with platelet function, so they interfere with clotting. So once bleeding starts, they tend to cause a lot of bleeding. They also cause renal toxicity, and one of the more common causes of renal failure in the Western world is excessive use of nonsteroidal anti-inflammatory agents. Specific drugs, ASA, even though it's the original nonsteroidal, has virtually no effect on the kidney, but it has lots of effect, bad, on the stomach. Acetaminophen, which falls into the same family, interestingly has virtually no anti-inflammatory effect. It does not cause bleeding. It does not have any negative effect on the kidney, but it's unfortunately becoming one of the commonest reasons for liver transplant in North America as people overdose on it or take too much for their pain management because it's directly toxic to the liver. So as I already mentioned, ibuprofen is relatively short-acting. Other drugs such as naproxen or ketorolac or diclofenac are longer-acting. They all have the same negative renal and gastric effects, but they also likely have cardiac effects that we haven't really been aware of in the past. And we didn't really learn much about this until a class of drugs called COX-2 inhibitors were introduced with the expectation of fewer side effects, particularly gastric, but also less bleeding. And these drugs were pushed incredibly aggressively, particularly to orthopedic surgeons, and were extremely widely used. The one that you may have heard of was Vioxx. And after about 5 years of use, it was discovered that the incidence of ischemic cardiac events, myocardial infarctions, and death in people taking these drugs was quite high, and they were finally stopped. And the interesting thing from a historical perspective is that one of the drug, not regulatory bodies, but examination bodies at my own university actually published the potential problem with cardiac disease years in advance of these drugs being taken off the market, and it was largely ignored. So let's talk a little bit about other drugs that are used to manage pain. Antidepressants are widely used and have been used for years, but they're used not because of their primary effect on depression, but because they increase norepinephrine and serotonin activity in the spinal cord. And they seem to reduce response to pain, and then in addition, they often activate the depressed chronic pain patient. So patients who have chronic pain very commonly are depressed. These drugs seem to be particularly effective for diabetic neuropathy and post-herpetic neuralgia, and are often used in the treatment of those two disorders. The two commonest ones are amitriptyline and nortriptyline, but there's also imipramine. There's a whole series of these things. So the newer antidepressant drugs, the serotonin reuptake inhibitors such as Paxil or paroxetine, and even newer drugs, the serotonin norepinephrine reuptake inhibitors such as duloxetine, have also been used to treat peripheral neuropathy and seem to have a positive effect. And then in addition, they also have their antidepressant effect, which can be useful in these patients. So another group of drugs that have been used in the treatment of chronic pain are some anticonvulsants. These reduce neuronal excitability and may help some patients with peripheral neuropathy. And the two that are most commonly stated are gabapentin and carbamazepine, which are used in the treatment of diabetic neuropathy and trigeminal neuralgia, which is a condition in which the face becomes intensely painful, and in which allodynia, this business of barely touching the skin, results in exquisite pain. And gabapentin and carbamazepine have been used in the treatment of that condition. They both cause some dizziness, some somnolence, confusion, ataxia. They're not drugs that you would take just for fun. There's a newer drug in the family called pregabalin, which is a new drug in this family. It has fewer side effects than gabapentin, from which it is derived, and it's aggressively marketed and costs much more than the other drugs. N-methyl D-aspartate receptor antagonists, NMDA receptor antagonists, can reduce central sensitization due to increased NMDA, which is a central nervous system neurotransmitter. So ketamine is a general anesthetic, which we've mentioned, but in small doses, it's an effective analgesic. It's also currently become a drug of abuse, and it has become a street drug, and the name on the street is Special K. Ketamine is also occasionally used for labor analgesia and analgesia prior to surgery, but only in very small doses. When used as an anesthetic or an analgesic in higher doses, it can produce the recovery phenomena that I mentioned in a previous lecture. Other side effects include nausea and vomiting, increased heart rate and blood pressure, and occasionally agitation and hallucinations. Carrying on, more drugs, alpha-2 agonists. The classic of these is clonidine. These are receptor drugs that work on the alpha-2 receptor, which is a central nervous system receptor. They can be given either orally or they can be given along with spinal anesthesia in a dilute concentration. They produce sedation and can produce severe postural hypotension. So in other words, when you stand up, your blood pressure drops, and that can lead to fainting or even loss of consciousness and seizures. So that's not a good thing. They produce a very dry mouth, and patients complain about that. The newer drug, dexmedetomidine, is very heavily marketed for ICU sedation. I'm personally doubtful that it's any better than clonidine. It certainly costs more. For migraine headache, there have been great problems finding substances that are useful. And one of the agents of drugs that has been found to be useful in some people with migraine are the 5-HT1 antagonists, 5-hydroxytryptamine-1 agonists. And the classic drug in this group is sumatriptan, but there's a series of drugs. They are used for treatment of migraine headaches. They can be self-administered by syringe, preloaded syringe. They can be, you can take tablets, or you can actually use nasal spray, which is quite quick because it's rapidly absorbed by the nasal mucosa, and you're right near the brain when you administer it. So it can actually be quite effective. They cause vasoconstriction, tightening of blood vessels, and reduction of inflammation of the cranial arteries. So the arteries that come on the outer surface of the skull primarily, some of them perforate the skull. And these are the arteries that become dilated and throbbing in migraine headache. This vasoconstriction can increase the risk of vascular beds, such as the cardiac bed, where if you get vasoconstriction, you can get cardiac ischemia and myocardial infarction. And it can also increase the possibility of stroke if it causes intracranial vessels also to constrict. Local anesthetics are used as an adjunct to opiates, either by way of neuraxial analgesia, or by epidural, for instance, or by subarachnoid block as in a spinal. They produce loss of sensation, muscle weakness, and hypotension. And they can't be used long-term because if you're using local anesthetics to control your pain, you lose muscle activity and motor activity as well as the pain. So they are used really just as a test to see if you can get rid of the pain rather than a treatment. Nerve blocks, there's probably 50 different nerve blocks which are done by anesthesiologists in block clinics to reduce pain. Some of them work quite well. None of these blocks produce permanent relief, but they can produce temporary relief in some situations and permanently relieve the pain in some situations, and we don't know why. So most of the time it's a temporary loss of pain. In a rare situation, the pain goes away and never comes back. We have no idea why that happens. These drugs can be delivered in every mode you can imagine, from oral, rectal, intramuscularly, intravenously, neuraxially, as I've mentioned, transcutaneously, epidural infusions, neuromodulation. There's all kinds of ways of treating this kind of pain. Now we're going to go through 3 very quick case reports, hopefully just to give you an idea of when you should use one modality and when you should use another. So the first situation is a 27-year-old man. He's been in a fight, and he appears in the emergency room with severe abdominal pain and evidence of internal damage. He asks for pain relief. What would you do to relieve his pain? So one thing you might consider doing is putting him on patient-controlled analgesia, and we've already discussed that in another lecture. This man probably needs opioids. He's got acute pain, he's got obvious internal damage, he needs strong pain medication, and there's no point at this level to start fiddling around with minor treatments and hoping that maybe they'll work. So patient-controlled analgesia allows him to have some control over his pain management, and we always advise patients to push the button whenever pain starts to build. And there's, as I mentioned earlier, there's a lockout period built in, which we program in, and so we can avoid serious side effects from the drug, such as respiratory depression, and it works very well. So this is a 60-year-old woman who's admitted to hospital with cancer of the lung. She requires a lobectomy. She requires a portion of her lung to be removed. This is associated with very severe postoperative pain. So what can we do to help? So in an earlier slide, we talked a little bit about this, and the ideal treatment for this woman is to put a thoracic epidural in, which will cover the area of her incision and allow her to deep breathe, allow her to cough, and allow her to get up and move around. So the major concern after thoracic surgery is not breathing properly, not clearing secretions, and developing pneumonia or other infections in the lungs that can lead to requirement for ICU care. But with this treatment, she'll be able to do all those things, and she'll be able to cough really well and keep her lungs clear. And the neat thing about this, the thing that makes it most valuable, is that unlike obstetric analgesia, which we'll get into in a moment, the epidural is placed high in the thorax rather than in the lumbar space, and it doesn't interfere with muscle activity in the legs. So the patient can get up and walk around, usually quite comfortably. And usually there's almost no pain or absolutely no pain associated with this incredibly painful incision. So here's our third case. This is a 62-year-old woman who complains of continuous nagging, aching pain over her back and legs. She's had complete neurologic and musculoskeletal exams, and they're normal, except that she doesn't move very much. She tends to, refrain from moving a full range of motion. So how should her pain be treated? So this woman sounds to me like she has chronic pain, and she will benefit best from interaction with a multidisciplinary pain team. She may benefit from group therapy with other patients with similar complaints. She should not be treated with opioids because she's very likely to become dependent upon them. And she has to be taught how to live with her pain, which is not an easy thing for people to accept, understandably, but it's really the gold standard in the treatment of chronic pain. So we're going to move over to another area completely. This is the treatment of obstetric pain. And the reason that I place obstetric pain separate from acute pain or from chronic pain is that it truly is unique. It's the only condition in humans that results in intermittent, very severe pain and intermittent periods of relaxation and loss of pain. It's really quite unique. It can be very intense, but unlike most pain, it's intermittent. When we provide pain relief, we have to take into account the fact that it's intermittent pain. And we must also take into account that we're dealing with a mother and a baby, and that anything that we provide to mom may very well make it to baby and may not be a good thing for baby to receive. So there are two areas of innervation for the uterus that come into play during labor and delivery. The first occurs in segments T10, thoracic 10, to the first lumbar segment. And this is the pain that women feel during actual labor. This is the abdominal pain they feel. And it, as we've already mentioned, is intermittent, severe, and it tends to become more severe as labor goes on. So it starts with a few fairly mild little pains, and then it slowly builds up over time and becomes extremely intense. The pain of delivery is served by nerves from S2, sacral 2 to sacral 4. And this is pain in the perineal area of the body. It's also intermittent and is related to the labor pain, to the contraction of the uterus, but it's a different kind of pain, and it tends to occur later in the labor phase. So in early labor, the pain is largely in the abdomen above the pubis, and epidural analgesia works like a dream. And you use low concentrations. You can completely remove the sensation of pain, but the woman will often continue to be aware that she's contracting, and that's the ideal situation. However, in late labor, the pain spreads over the entire abdomen and into the perineum and becomes much more severe. And at that point, we use higher concentrations of local anesthetic in the epidural to provide pain relief in that area. The local anesthetics are not transferred across the placenta to the baby, so there's no concern about fetal toxicity from local anesthetics. However, opiates are transferred to the baby. So we usually have very low doses of opiates included in our epidural, but you must be very careful not to rise with the pain, rise the opiate level, because that is transmitted to the baby, and it may cause respiratory depression in the newborn. There are lots of other modes of obstetric pain relief, but I can say with some certainty that nothing works as well as epidurals. But other conditions or other modes such as psychoprophylaxis, which is usually mom plus her partner working on breathing, certainly can help in the earlier stages of labor. And certainly mom and the partner, dad in many cases, feel like they're participating in something together, and they can work as a team. Massage, baths, and acupuncture have all been used to varying degrees of success. Nitrous oxide, which is breathed through a demand valve, so it only goes to the patient when she takes a breath in, is also used. So the patient has to be taught how to use it. She has to be told that as soon as she starts to feel the contraction developing, she should take a big breath of nitrous oxide or a couple of breaths. And this will produce quite effective analgesia, but only of intermediate potency. So later in the labor, it's probably not going to be terribly useful. Can cause sedation and confusion, and it should never be delivered by the partner. In other words, if mom's lying there and contracting, the husband should not put the mask on and hold it in place. It's important that the patient control it, takes her breaths, and drops the mask so she doesn't have an overdose of the nitrous oxide. Intravenous narcotics are sometimes given, but remember what I said. They do transfer to the baby, and there's a potential for respiratory depression in the newborn. Ketamine is used primarily, if it's used at all, early in labor in small doses. And it produces good analgesia. It is transferred to the baby, so you can have a baby that's anesthetized, and you don't want that. So it's only used early in labor and in very small doses. And intramuscular narcotics have been used. They're not effective generally because they're not absorbed quickly enough to be effective. But they're longer lasting. They do go to the baby, and they can cause all the problems in the baby that you just don't want to see. So the goal of obstetric analgesia is to provide the patient with as much comfort as possible without affecting the fetus. Many drugs can cross the placenta and have an effect on the baby, but local anesthetics, as I've mentioned, do not. Care must be given with opiates, are given because they do cross. And labor, the good news is labor is not delayed by epidural analgesia, nor is the rate of C-section increased by epidural labor analgesia. These are both statements that are commonly made, and there's a vast amount of evidence that says that they're simply incorrect, that labor is not affected, nor is the C-section rate affected. So this is the International Association for the Study of Pain. If you have further interest in this subject, you should look at this website. It's a very good website. So in summary, in this lecture, we've talked about a number of drugs that are used in the management of pain, both their usefulness and their side effects. We've had 3 very short case presentations and an appreciation, I hope, of how pain is managed in different conditions. And we've ended with that unique form of pain, obstetrical pain, and how we use epidural and other forms of pain management to safely care for the mother and for the baby.